Good afternoon. My name is Olayinka Remo. Once again, this is your Synergy International Nursing Network, CBT, OSCE study buddy program. Today, it's purely the OSCE preparation, which can also be the CBT, and what we're going to be talking about pressure area assessment, and of course, how to measure that using the Waterlow. All right, so I understand that this might be new to some people and it might not be new. So as nurses, we know that we all take care of the skin. Skin is very important. So pressure area risk assessment, it's very important when it comes to skin management, when it comes to the care of a patient. As soon as the patient enters into the ward, into your admission, it's important that you check the skin. But in Ireland and most English-speaking countries, so there's this Waterlow scoring. It's called Waterlow. That's just the name of the scoring procedure, or like a chart. So you have criteria there that you can use to measure who and what you should check out for when you're assessing a patient. So today I'm going to be showing you some materials gotten online, and I have no copyright of this materials. It's just for learning guide. And so we're going to be I'm going to be sharing this material. So if you take a moment there, get a pen ready to take some jottings. If you have any question, you can drop it in the chat box. If you need any clarification, just drop it in the chat box in the comment section, and we can discuss this after the class. I'm going to start with this document here, this presentation by Dr. Karen, Montana State University, talking about conducting a comprehensive skin assessment. So as large as the skin is, that we know that the skin is the largest organ in the body. So assessment is more than the surface. It's not just about, is the skin clean? Is it dry? It's not just about, oh, is this person light skinned or brown skinned? So it's more than the surface. So if you look at that, the epidermis, the dermis, like the layers of the skin, we also want to think about the sweat gland as well, the oil gland, the follicles, and of course the nerves. So all these things have a major role to play when it comes to skin assessments. So that is Professor Montana there. I can send you this material if you want to know. The reason why I'm using this material today is because it's very important that we use evidence-based, products or information, and not just something from the Google. Right. So Professor Montana is a member of the editorial board of the Ostomy Wound Management and Advances in Skin and Wound Care. So you can trust that you will have a lot of useful information there. So this particular slide is talking about the goals of comprehensive skin assessment, how to conduct comprehensive skin assessment, treating comprehensive skin assessment as a separate process, and of course, talking about the documentation. I'll take a look at this, at the picture there. You see, this is what kind of wound is this? The location, just look at it. So talking about skin assessment is important. Sometimes you have a patient comes into your ward with an existing wound. And so if you don't take your time to assess, that could actually lead to some litigation issues if the family or if the patients are claimed that the wound was not brought into the hospital or into your units. So you need to document an existing wound or any existing skin issues before, as soon as you are admitting the patient. That's why it's very important. The patient comes to your ward or to your units with this type of wound. Just a reflective question there. What type of wound will this be? How will you report it? What are you going to take out for? What are the questions you're going to ask? So all these things are what we're going to talk about. So attributes of comprehensive skin assessment, it's the process of examining entire skin for abnormality. Entire means from head to toe. Requires you looking at and touching the skin. It's not just mere looking. You also need to touch, you need to palpate, you need to check properly from head to toe. The reason why we are doing comprehensive skin assessment is because it's important to identify any pressure ulcers, to find out are there any lesions or skin-related factors that predispose the patient to develop pressure ulcer, and what are the factors, including excessively dry skin or moisture-associated skin damage. So look at this. This is the sacrum, this bottom of this patient, and you can see there, it looks more red, very red. You don't know if it's blanching or not. Okay, there's some cream applied there. Most of the patient, especially incontinent patient, the geriatrics, because they are incontinent, they usually are at risk of developing moisture-associated skin damage. This might not be entirely like a pressure sore, but it can actually lead to pressure ulcers as well. So we need to check out for this if there is a risk factor. It's important that you're able to identify other important skin conditions. A patient might have acne, might have some dermatological condition pre-existing, so you should be able to document this. All right. There are different stages of pressure ulcers that we know as well, so you should be able to identify which stage is this, what can you do at this stage so it doesn't progress to the higher stage. And of course, identify care planning needs that is suitable and appropriate to the person, making it a person-centered care. So we are going to talk about how to conduct comprehensive skin assessments. There are standard protocol for comprehensive skin assessment. There are 5 parameters of a comprehensive skin assessment, and there is a separate skin assessment of bariatric patient, that is patient that are excessively obese. Now, when a patient comes to you, it's important that you explain to the patient and the family that you will be checking the patient's entire skin. You can imagine, you can't just walk into the patient and start checking and opening the clothes. You have to take consent. Apart from taking consent, you need to explain the reason, the essence of checking the skin. They might not understand the importance of this, so you need to let them understand why you need to check their skin. Explain what you're looking for with each site. You need to continually talk as you go ahead. So it's not just a matter of, okay, I've told her, and then you're touching the breast, and then you're going down, you're going to the genitals. So you need to, now I'll be examining your breast for any lump, I'll be for any, differentials. So you need to communicate this as you go ahead. It's important that you conduct the assessment in a private space and make sure that the patient is comfortable. Okay, wash and sanitize your hands before and after the assessment. This is very important. It's also important that you wear gloves and change them as needed. There might be minimum exposure of body parts, so make sure you provide privacy with a sheet or cover. Even though the room is locked, it's not enough for you to just close the door. You also still provide some extra privacy for the patient using a sheet or cover. Ask for help to turn the patient as needed. So if you need help, you need to ask for help. You need to let the patient know that somebody else will be coming to join you in the assessments. So above all, it's important that you follow your facilities policy and procedure when it comes to skin assessment and scoring. So while we are doing our skin assessment, it's important that we pay attention to the skin beneath and around any devices or compression stockings. For instance, a patient on that has catheter, you need to pay attention to the skin around the insertion parts of the catheter. You need to pay attention for a patient that has cast, any device at all, oxygen mask, tracheostomy. So you need to pay attention to the skin beneath and around any devices, even compression stockings. So it's not enough that a patient is wearing compression stockings. So take it out, check it, and then you can reapply these compression stockings. Also pay attention to bony prominences like the heels, the sacrum, occiput. I know you can remember and try to revise the pressure areas of the skin. So skin to skin areas such as the penis, back of the knee, inner thigh, and buttock. So you look at these places they are very important. So all areas where the patient lack sense of to feel pain or had a breakdown previously. So you need to pay attention to this, especially for patients with diabetes. Also pay attention if the patient is getting epidural or spinal pain medicine, because this can actually reduce their the sensitiveness, and they might not know if there is any cuts or any injury to their skin. There are 5 parameters of comprehensive skin assessment, okay? And like I said, this you need to check with your organization policy as well. So temperature, sugar, color, moisture level, skin level. What are you checking for? So for the skin temperature, you need to palpate with your hand to assess the skin temperature. Is the skin warm? Is it cold? This can help you to indicate skin damage. So this includes when you're touching, especially if the skin is red, you might know the stage of the pressure sore. So if the skin is if the redness is blanching and things like that, it might help you to determine, oh, this is a stage 1 pressure ulcer. Any suspected deep tissue injury, you might also know that by, touching, palpating with your hand. Pre-ulceration in the diabetic food or any inflammation or infection. This can also be detected when you palpate with your hand. Parameter 2, that's the skin to gore and firmness. So the skin normally returns to its original state quickly when stressed. So can you tense the skin? So you need to feel the firmness of the skin. Is it tensing? Is it denting? So the skin may be slow to return to its original shape in older or dehydrated patients. You might also know this as well for patient that has oedema. So is it beating or so? So you need to assess the skin properly. Now that's a picture of how you can tense the skin and see if it retracts easily back to its original stage. The skin color is also an important parameter. So you need to be able to compare adjacent areas of the skin for colors. Look, is this area brown? Is this darker, and things like that. So redness can indicate many skin problems, as we all know. It could indicate pressure ulcer, rash, infection, or even cellulitis. So important that you pay attention to the color. Deficiency can also affect the skin. All right, so vitamin C deficiency causes purplish blots on the likely traumatized area, and zinc deficiency causes redness of the nasolabial fold and eyebrows. So blanchable versus non-blanchable erythema. We use this word often when it comes to skin assessment. Oh, the skin is not blanching. What does that mean? So when you press on the skin, you want to see, does blood flow away easily, and does it come back easily from that surface? That is blanchable. So if it takes more time for the blood flow to return, when you press down on the skin, it goes pale initially, and then blood flow will come back. So you look at it, does the blood flow, return of blood flow to the area, was it fast or was it slow? So, or maybe it did not, it was just plain like that. So that is non-blanchable. So a purple or bruised looking skin as well, you need to take note of that. Is the skin paper thin? Are there dark or reddened areas in the skin? So pay attention to that. A darkly pigmented skin does not blanch. So it's important that we, of course, for dark skin color people, African, it might be very difficult for you to assess is the skin blanchable or not. Talking about skin color, redness. So a reddened skin on the sacral area can be from a variety of etiologies. So look at this picture there. Look at that. That's from a moisture-associated skin damage. You can see how red it is. Okay. And the other one looks more like a stage 1 pressure ulcer. So make sure to get the etiology right so you can treat the cause appropriately. So how to know which one is, how the difference between moisture-associated skin is, that one could be blanchable. A stage 1 pressure ulcer will not blanch. Moisture, skin moisture, that's another thing, okay? Moisture-associated skin damage, skin can be dry or damaged from too much wetness. So of course, the etiology is also very important. You can see the catheter, that's more like a drainage site there for that patient. So you look at the wetness of the area that could predispose the skin to a lot of infections or breakdown. So etiology could be incontinence, urine, stool, or both. Also, maybe patient with osteomy and things like that. Wound exudates, perspiration, when a patient sweats too much leads to fever, or between skin folds, especially in bariatric patients that are very fat under the breast, under skin folds all over the skin. Osteomy or fistula that leaks, I mentioned that. So make sure to get the etiology right so you can treat the cause appropriately. The fifth parameter is skin integrity. So what's the integrity of the skin? Usually the skin should be intact, it should not be broken. There should not be any break, in the layer of the skin. So if the skin is not intact, identify the etiology of the skin problem. Is it due to pressure? Is it due to peripheral vascular or neuropathic issues like diabetic? Is there any skin tear? Is there any trauma whatsoever? So please get the etiology right so you can treat the cause appropriately. Now we talk about the skin assessment of bariatric patients. Usually the inner aspect of the thighs and skin folds need to be looked at. There could be rashes there and all over the skin, maceration as well. And infection, which such as bacterial candidiasis, are very common, and there could be breakdown in the skin. So look at the perineum. Sometimes there could be dermatitis or candidiasis. The extremities as well, there could be issues with vascular changes, edema and lymphedema for bariatric patients. So that's about the parameters, what you need to check out for in the skin. And let's talk about the process of comprehensive skin assessment. So it requires a specific focus by the staff. And like I said, must be standardized and ongoing. That's why we require a standardized instrument where that's where Waterlow scoring chart comes in. Part of this as well, the frequency of this matters. So the frequency of the skin assessment will depend on the need of the units, may depend on the patient, may be as often as every shift. So usually here in Ireland, it's important that you assess the skin of a patient at every shift. Then you hand over to the next shift. So it is not once in a week, it is not once in a day or once in a month. It is usually at every shift. In most often daily, and when the patient is newly admitted is important. I need you to pay attention to this was when do you conduct skin assessment? What's the frequency? So it could be new daily, maybe on a newly admitted patient, when the patient is being moved to a different level of care, a patient is being transferred to another unit, or a patient is being discharged. So if you are discharging a patient, you need to also check the skin before discharge. Each time you apply oxygen, check the patient's hair for pressure areas from the tubing. Okay, and also check bowel sound. Look at the skin fold. We position the patient in bed and check the back of the patient's head each time. Okay, it's very important. As well, each time you auscultate lung sound or turn the patient, check the patient's shoulder, the back, the sacral, or the coccyx. Like this thing takes microseconds for you to do, so it's not a big deal. Check the patient's, a male patient's catheter, check his penis. There could be any reaction there. Position pillows under the patient's calves, check the heels and the feet, make sure that the heels is not resting on the surface or the bed, so usually lifted up. Use a handheld mirror to adequately visualize the area. So you might need that as well, because it will be too hard for you to be bending down, be checking the heels where the patient is lying down. Also, how to integrate the skin assessment into your normal workflow. Each time you check IV sites, look at the patient's arms and elbow. The patient might have pressure sore there. So leave the patient or provide care. Check exposed skin, especially on bony prominences. Remove equipment and check adjacent skin if possible. For instance, if a patient is on any restraint, maybe a belt, or it's important that you check splint, oxygen tubing, and endotracheal tubes. I think I mentioned this before. Now, as beautiful as skin assessment is, if you don't document it, it is not done. It is being said like anything not written is not done. So document it, document your reports, document anything you find. And again, to make the documentation standardized, that is why there is a standard instrument, the Waterlow scoring is in place. Okay. So documenting results. So think about your patients, like for each patient, check whether the patient has pressure ulcer, how many pressure ulcers has he or she has, what's the highest stage, and what is the treatment plan. So thank you so much. We're going to pause here right now, and we will come back and talk about check the Waterlow scoring chart and what we can do with it. Thank you very much. If you have any question again from this presentation, please feel free to ask. So you're welcome back to talking about the pressure area risk assessment and Waterlow scoring. Now I'm going to be showing you the Waterlow charts, Waterlow pressure scoring chart, so we can understand what and what we should look out for and how to use the charts. So there are different charts. The chart varies with you depending on your organization. So the structure varies, but the contents are similar. And are usually almost the same thing. So I'm going to be sharing with you now. All right, so this is just like a blank Waterlow pressure area chart. So we can see it, that you have the name, date of birth, admission date, ward, diagnosis of patient. All right, this one is from the RCSI website. That's just a template there. So question or area to explore. Remember when we were talking about the assessment or what to check. So gender has its own scoring. So a female will score 2. You know why? Because of the risk that it takes for females to develop pressure area. So for female, it's higher because of the body structure, the skin type, and things like that. The male will score 1. Age as well has its own scoring guide. So 14 to 49, 1, up till 81 plus would be 5, because by 81, the person is old and frail and all that. So the skin will definitely, be very susceptible to damage of pressure sores. You also score the height and weight, which is the BMI. So you look at the BMI score, it's scored between 0 and 3. So you give the required score per date. You can see the dates here. So you need to write the date and check. Skin type, what's the visual risk area? Skin type, is the skin healthy by mere looking? Is the skin tissue paper-like? Is it dry? Is it oedematous? Is it discolored or broken skin? So you give the required score as well to it. We'll also look at mobility is another thing, scoring criteria there. A patient that is fully mobile will score 0, whereas a patient that is bed chair bound will score 5. So looking at the different categories like that. Continence is another criteria. So a completely a patient that is not incontinent, that means the patient is continent of both urine and bowels, so we score 0. And on the other hand, the patient that is catheterized or incontinent of feces will score 2. Doubly incontinent, that means urine and feces will score 3. Look at the appetite. What's the nutritional value? What's the nutritional strength of the patient as well? You would put that into consideration. Usually we have the MUST score. So we're still going to talk about the MUST, which is the malnutrition screening tool. So this one is used to determine if a patient has poor intake or not. So you also need to score that. Patient appetite average, poor, the patient on NG tube or new by mouth, maybe nothing. So you score that as 3. Now, there are special risks of tissue malnutrition as well that need to be scored. A patient that has terminal cachexia will score 8 there. So, or a patient that is smoking will score 1. Other risks, special risks like neurological deficit like diabetes, CVA, paraplegia will score 4 to 6. So you give as appropriate. And you see like that, special risks, a patient on that has orthopedic surgery, or a patient that has been on A&E trolley or table more than 2 hours will score 5. There are also special risks like medications. The patients on high dose of steroids, on cytotoxic, anti-inflammatories, all these as well will be scored. After this, you look at the total score. What's the total score? You need to total it. So if the total score is 10 plus, the patient is at risk, 15 plus high risk, and if it's 20 plus, the patient is very high risk. So, and in your OSCE, what you'll be required to do once you have done this, you'll be given the scenario, you'll be given the patient details. All you just have to do is to chart the details in the chart there. So you score it and then you come here. So what do you do depending on your score? So this is the assessment. If the patient falls into any of the risk categories, then preventative nursing is required. And this requires a combination of good nursing techniques and preventative aids to prevent pressure sore. So look at this chart there. What's the preventative aids, and what will be your nursing care? So usually specialized bed and mattress will be prescribed for patients that are at risk. A patient that is 10 plus, the score is 10 plus, that is overlay or specialist foam material will be required. And your general nursing care will be frequent changes of position, use your clinical judgments, and you may use pillow as appropriate. You look at it straight to patient that scored 20 plus, you require a low hair loss or an alternating pressure mattress. And they might need pain control for that kind of patient. Cushions may also be required. So you see the different type of cushions as they apply to the different Waterlow scoring. Bed clothing as well. Avoid plastic draw sheets, ankle pad, tightly tucked in sheets, and all that when using specialist bed and mattress. So those are the things you need to pay attention to. The skincare will be like general hygiene, no rubbing, use the correct lifting and positioning, cover with appropriate dressing if there is any wound or exposure. So also think about patient handling techniques, using the correct lifting techniques. If you're using oils, you're using any transfer devices, it's important that you take extra care. If treatment is required, so first remove the pressure, it's very important. And let's look at the different classification there. Remember, I talk about non-blanching hyperemia, stage 1 pressure sore. The wound will be red, clean, but not healed. Okay, so you need hydrocolloid, arginate, hydrogel, silatic foam for the treatment. For an ulceration progressive stage 2, the wound is yellow, infected, or inflamed. So you need arginate, hydrogel, hydrocolloid. And for a wound that is ulceration extend to stage 3 to be infected, then you need arginate ribbon or rope, non-adherent topical antimicrobial dressing. Infective necrosis, which is like a stage 4, is the wound black or necrotic. So you need you need a deep surgical excision, hydrocolloid, hydrogel. So these are the 3 different types of treatments. Now again, there are new updates regarding the treatment of pressure sore. So you might want to check with your hospital policy regarding referral maybe to tissue viability nurse that will be able to recommend and advise on the best type of treatment to give to patients that has pressure sore or even moisture-associated skin disorder. So that will be the end of today's class. Thank you so much for waiting. Thank you for your patience. And like I said, this is revision class for you all. So the Waterlow scoring, like I said, the charts is available in every healthcare facility in Ireland. And the only changes you might have would just be the maybe structure, but the contents are all the same. So basically, we've talked about we talk about comprehensive skin assessment today. We'll also talk about the goals, why, and the criteria. What are the things to check out for? What are the parameters? We've talked about the Waterlow scoring system as well. Okay, why it is important and what to check out for and what to document. So these are few things. For the exam, the OSCE, what usually happens is you'll be given a case scenario, you'll be given a scenario of a particular patient, and you'll be asked, to give your own assessment of the skin, usually using the Waterlow score. So assess the skin, score it, what's the score, and what would be your recommendation. So again, you're not expected to say anything offhand or cram anything. You're only expected to be able to say, this is what I would do. This is what I would do. This is what I would do, and like that. So if you have any question when it comes to Waterlow scoring and skin assessment, please feel free to ask. Send in your question into the discussion forum or into the chat group box, and I'll be able to take that. I will also be sending in the scenario for your practice to be able to use the Waterlow score. I also send a scanned copy of a Waterlow scoring charts here for skin. So you are expected to print this out and use the scenario to complete the chart and score it and send it back to me via the WhatsApp chat group or the discussion forum. Thank you very much. Again, my name is Olayin Karemu. I am a study buddy. Do have a lovely day.